Joining the Division of Rheumatology Grand Rounds. A couple of reminders before we start the session. This session is currently being recorded and the recording will be posted later on our website. There will be a Q&A session at the end, so please add your questions in the Q&A feature and not in the chat box. It just makes it easier to moderate the questions. And now I'll let Dr. Weisham introduce our speaker for today.
Hello, everyone. It's an honor to introduce Dr. Jinoos Yazdany to speak today at our Grand Rounds. Dr. Yazdany is a professor of medicine at UCSF, chief of rheumatology at the UCSF County Hospital, as well as the co-director of both the UCSF Lupus Clinic and the UCSF Rheumatology Quality and Informatics Lab. She has a long focus on understanding and mitigating disparities in people with rheumatic conditions, with a particular focus on those with lupus. She's also key to the development of the ACR RISE registry, which has provided a source of data that informs both local and national healthcare delivery quality assessments and improvements. More recently, she co-led the Global Rheumatology Alliance, which has produced numerous impactful publications informing us on the outcomes of people with rheumatic conditions infected with SARS-CoV-2. She serves on numerous journal editorial boards, has many active grants and over 150 publications. She is an impressive researcher. In addition to that, she's a brilliant clinician who has taught numerous fellows, myself included. So it's an honor to be able to introduce her today. She's going to be speaking on health disparities in systemic lupus erythematosus. Thank you for joining us today, and I'll hand it over to you, Dr. Yazdany.
Hi, everybody. Really a pleasure to be here with you today. And thank you, Katie, for introducing me, even at the end of your maternity leave with twins. That's incredible. So today we're going to talk about health disparities, and I'm going to focus on some of the research that we've done in lupus. And we're really going to cover a broad array of topics, and hopefully we'll have some time for questions at the end. So we'll start with some definitions. Health disparities are the differences in the incidence, prevalence, mortality, and burden of disease and other adverse health conditions that exist among specific population groups in the United States. And I'm going to show you some of the data that we've generated in lupus about things like incidence, prevalence, and mortality. And I also study healthcare disparities, and those are disparities which relate to the differences in access to or availability of facilities and services. And a large part of my career has been studying healthcare disparities and differences in access to care. So with that, I'll take us back in time to when I was a fellow in rheumatology at UCSF many years ago, and I saw a patient that really sort of changed the course of my research career and also my clinical interests. She was 22, and she had SLE that was manifested by lupus nephritis. She had multiple positive autoantibodies. She'd actually initially presented in the year 2000 with nephrotic range proteinuria. She had had a biopsy. It showed class 5 lupus nephritis, and she was treated with high-dose prednisone monotherapy. She transferred her care to UCSF in 2003 to my first year fellow clinic back then, and she still had nephrotic range proteinuria. Really, her proteinuria had never been suppressed. And she was still taking a pretty high dose of prednisone and really had been on between 20 and 60 milligrams sort of continuously for the 3 or 4 years before I saw her. At this point, her serum creatinine was 1.6, and we performed another biopsy, and it showed that she had class transformation. She now had class 4 and as well as 5 lupus nephritis. The young woman in front of me had profound steroid-related adverse events. She had bilateral hip AVN. She had striae all over her body. She had osteoporosis. And I remember just feeling like, we as a healthcare system could have perhaps done better for this patient, including, perhaps trying other immunosuppressive therapies. and ensuring that she had the tools she needed to, self-manage her lupus. So, that really was the beginning of my research agenda and sort of the problems that I and my research group has tried to address over the years. So first, trying to understand the incidence and prevalence of lupus in the United States, trying to fill knowledge gaps in terms of health outcomes because they are not very well characterized in many of our most vulnerable populations, trying to understand the mechanisms of disparities. And then more recently, trying to develop interventions to actually reduce health disparities. And so we'll go through each of these, sort of highlighting some of the studies that we have done here at UCSF with collaborators to answer these questions. So the first study that I'll touch on is the California Lupus Surveillance Study, or the CLSP. And this study arose from sort of a basic problem that we had about a decade ago, which was that we really didn't know how many people in the United States have lupus. You all know that this is a hard disease to classify. We have these complicated classification criteria. If you use things like, claims, often, the sensitivity and specificity is poor. So it's hard to count the number of cases of lupus. And the CDC, I think with a lot of foresight, actually funded several registries around the country to actually solve this problem. And, this was a very special and ambitious effort because they gave us, my colleague Maria Delera at UCSF led our effort here, public health authority to actually count the cases of lupus. And what that meant is that without, patient-informed consent, we could go into academic centers, community clinics, hospital records, laboratory records, and actually count every single case of lupus by quantifying the classification criteria from the medical record. So this was a super ambitious effort in San Francisco County and allowed us to actually quantify the number of cases of lupus in the population in our geographic area. And other registries that were set up in Michigan, Georgia, New York, and the Indian Health Service did the same thing. And recently, Pete Ismerly actually meta-analyzed all this registry data. And so these are actually the best estimates that we've ever had of how many people have lupus in the United States. And they do indeed show that there are profound health disparities. So I think one of the things that really stood out from this work, that the racial and ethnic group that has the very highest prevalence of lupus in the United States are American Indian and Alaska Native females, with a prevalence of 270 per 100,000. Next highest are Black females, 230 per 100,000, followed by Latina females, 120 per 100,000. The prevalence in white females is 84, and that's about the same in Asian females as well. And so this data allowed us to estimate that about 200,000 people in the US have lupus. Obviously, there are confidence intervals around this. It might be a little lower or a little higher. But this tells us that, lupus is an uncommon condition, but it's not quite so rare to have like an orphan disease designation, which would require, fewer than 150,000 cases. And now that we, were able to find all the people with lupus in San Francisco, the CDC gave us a wonderful opportunity to actually follow these people longitudinally in a cohort study, which we called the California Lupus Epidemiology Study, or CLUES. And, we went back through the rheumatologists and primary care physicians that were following these patients and asked if they could contact them for the study. And then we enrolled, a group of them into this cohort. This is a very ambitious study in that we're trying to actually do it in 4 languages. It's probably the hardest study I've ever done, just because everything is in English, Spanish, Cantonese, and Mandarin, including all of our, patient-recorded outcomes, our survey forms, all the study visits. We have to have staff that speak, all of these languages. All the databases are in multiple languages. Anyway, it's quite complex, but I think an incredibly rich source of data. And what we wanted was really to very deeply phenotype these patients. And so they come in for a baseline visit. Either Maria Delera or myself see these people in person, take a complete medical history, record all of their disease activity and damage assessments, record all of their previous and current lupus manifestations. And we also collect biospecimens. And then patients also participate in a 1-hour telephone or in-person interview with one of our staff, and we collect patient-reported outcomes. We have DNA, RNA, and all sorts of PBMC is available on these patients. And this study has been used by trainees to do genetic studies, epigenetic studies. We're looking at proteomics, DNA methylation profiles. People have done single cell sequencing. So just a very deep and rich collection on these people. And about 333 people have had all of these assessments, including the in-person clinical visits. There's a smaller number that are just interviewed on the phone because they weren't able to come in for the clinical visit. And you can see that this cohort is very diverse. Actually, the largest number of people are Asian, followed by white and Latino individuals, and then a substantial number of Black individuals as well. So let me just summarize this first part of the talk in terms of disparities and disease prevalence. The CDC lupus registries confirmed what we already knew, that women are 9 times more likely to develop lupus. But I think importantly, they really highlighted the impact of this disease on Native American, Alaskan Native populations. I think confirmed what previous studies had shown about African American women being 3 times more likely to have lupus. And among these populations, lupus is not a rare disease. 1 in 250 people would have the disease in these groups. Latino populations are also more likely to develop lupus. And so I think this really highlights a key healthcare disparity in disease prevalence. Okay, moving on to health outcomes and characterizing these in people with lupus. So this was an older study published in 2002, and one of the first studies to really illustrate the striking disparities in mortality from lupus in different groups. And so the black lines in the top here represent the mortality rate in 3 different age groups among Black women. And on the bottom, 3 different age groups among white women. And you can see that across all age groups, Black individuals had a higher mortality rate from lupus. So we've gone on over the last few years to look at other racial and ethnic groups in terms of mortality. This was a nice study that one of our fellows, Christine Anastasio, did, looking at the national inpatient sample and looking at in-hospital mortality in people with lupus. And I think what was interesting about this study, she did find higher mortality among Black patients, but also found higher mortality among Latino patients, and strikingly, actually, among Asian individuals with lupus. And this has certainly been my clinical experience locally here in San Francisco. I see very severe disease among some of our individuals with Asian descent who have lupus, and that's nicely highlighted in this study. This was also a very recent study that Milena Gianfrancesco, one of our junior faculty, did, published in MMWR. where we actually took that CLSP cohort, or population-based lupus cohort, and we matched those individuals using the National Death Index and looked at mortality in that population. And what we found, not surprisingly, if we just look at the bottom here, the standardized mortality ratios across all racial and ethnic groups were significantly higher in people who had lupus. But look how striking these SMRs are among Asian and Latina women. Four times a higher mortality, 6 times higher mortality. And again, this is very consistent with my experience in the clinic, where we're seeing really severe disease in some of these racial and ethnic groups. One of our research trainees, Ernest Manending, did this nice study using, again, the California Lupus Surveillance Project, and looked at the timing of lupus manifestations across different racial and ethnic groups. And you can see that Asian individuals develop lupus much earlier in their disease course compared to some of the other racial and ethnic groups. We also see striking differences in Black and Latino patients compared to white patients. And this is a very recent study just published a couple months ago by one of our fellows, Alfredo Aguirre. And he looked at a variety of lupus manifestations, and also combined different organ manifestations into this composite measure. And he found that compared to white participants, Latino and Asian participants had much higher rates of multi-organ disease following their lupus diagnosis. You can see here that the green and purple lines are Hispanic and Asian individuals. And you can just see that multi-organ disease develops sooner and more frequently in these populations. So that's just a group of studies that we've done to characterize health outcomes. Let's go on to talk about studies that look at some of the mechanisms of disparities in these populations. I really like this model of the determinants of health, because I think it just reminds us that in addition to some factors like age, sex, and perhaps biology or genetics, there are a wide variety of things that impact the outcomes of our patients, including things like individual lifestyle factors, social and community networks, and a wide variety of social determinants of health, whether it's access to food, education, work, living and working conditions, people's employment, water and sanitation, their healthcare services, their housing. And as we try to unpack, why we see disparities in disease and the outcomes of diseases like lupus, we really have to look across a wide variety of factors to really untangle the complexity. And, especially as we think about social determinants of health in this population, I think it's just so important to realize how multifaceted this is. Economic instability, neighborhood and physical environment, education, food insecurity, people's community, and, their access to and availability of healthcare are all important. And I think increasingly we're also realizing that across many of these domains, some structural racism and discrimination are also at play. And we really have to think, broadly as we try to do research to understand the causes of these disparities and to develop interventions to address some of these things. So I'm going to take you through some of the studies that we've done in these various areas, and I'll start with some of the studies that we've done to examine poverty. So this was an interesting study that was led by Ed Yellen, using a data source that predated the CLUE study that we've been talking about, This was called the Lupus Outcome Study, and it was a large longitudinal study of about 900 people with lupus who lived in the San Francisco Bay Area. And people participated in a yearly interview, and we collected various outcome measures, including disease damage. And so what Ed did in this study was actually look at the outcome of damage in people who had lupus. And then he tried to see, what the relationship was between poverty and damage. And the thing, that was, I think, novel about this study was that he looked at people who remained in poverty, and then he looked at people who left poverty. And, they left poverty at different times from our baseline interview, either, 1 year later, 2 to 3 years later, 5 to 11 years. And then there was a group of patients who were never in poverty. And you can see that there's this incredible dose response relationship between, poverty and the length of time in poverty and disease damage as an outcome. And I think the thing that was really remarkable is that those who were able to exit poverty, their economic conditions improved, actually had disease damage that then reverted to those who were never in poverty. And it just really illustrates what a powerful effect poverty impacts on disease outcomes in lupus. And Ed wanted to understand the mechanism, like why, what is it in particular in this group of patients that is leading to this very striking outcome. And he undertook this qualitative study in 28 people with lupus from diverse communities. And I think there's a lot of rich things in this paper, but I think two things that patients said again and again is that those who were in poverty reported having to deal with food and housing insecurity on a daily basis, and having to relegate dealing with lupus to a time of disease flares, just a very important and recurring theme. And then many reported, sort of stress, whether it was crime in their neighborhood or even financial stress, as sort of triggers of worse lupus disease activity. All right, so that was poverty. Let's move on to talk about access and quality of care. And this is one of my patients, I think, who really illustrates the impact of access to care on lupus outcomes. This was a 39-year-old woman who I took care of at UCSF, and she had lupus nephritis since about 2006. And this patient had periodic lapses in her insurance and her drug coverage. And this is her EPIC flow chart for her protein to creatinine ratio on the y-axis. And so she had been actually doing quite well on mycophenolate for some time, but in 2012, she lost her health insurance and she was not able to continue to refill her mycophenolate. And so she had a giant disease flare, 10 grams of proteinuria in the hospital. It was a complicated and long course. Finally got her back on the MMF, and she started to do better. But then unfortunately, a few years later, she had been on a patient assistance program for mycophenolate at that time, and she lost access to it temporarily. She had another disease flare with her proteinuria going back up to above 5 grams. And then, got her back on the MMF and she did well. And then in 2015, actually her co-payment for MMF increased and she started splitting tablets, not able to take the drug regularly, and sort of, had a rocky course, never really sort of returning to her baseline proteinuria. And I think this just illustrates the terrible position that we put so many patients in. They have a chronic disease and they're at the whim of our fragmented healthcare system, our crazy insurance policies that make no sense and actually result in more healthcare spending in the end, not to mention just all of the stress that this poor woman went through. So obviously, and I'm sure many of you have patients like this in your clinic, and it's just really challenging also to be a physician and to watch these outside factors sort of affect our patients. So, early on, one of the things I wanted to do is measure some of these things. And so this was one of my first projects, actually started during fellowship, to develop quality measures for systemic lupus. And we went through, extensive consensus panels and so forth to develop these measures. And then over a period of years, looked at a variety of different ways that we could improve the care of people with lupus, basic things, whether it's screening them for cardiovascular disease or managing their hypertension or treating osteoporosis, making sure that they're immunized. And on average, people with lupus receive about 50 to 60% of recommended care. This is actually not that different than all chronic diseases. In general, it's hard to, ensure that people get all of the things that they need. When we looked at, who was less likely to receive some of the things that we thought improve outcomes in lupus, not surprisingly, there was an effect by race and ethnicity. Populations that were non-white were less likely to receive high quality of care. Poverty also had a significant impact, with those who were living in poverty having lower quality of care. What was interesting about this study is that once we actually adjusted for access to care, including health insurance, some of the effects by race, ethnicity, and poverty actually went away, suggesting that really it's, access to healthcare that is, at least partly driving some of these disparities that we're seeing in healthcare. This was one of the more depressing studies that I've done in collaboration with Karen Kostenbader at Harvard, looking at Medicaid beneficiaries with lupus. And we were just interested in understanding whether or not people who had incident lupus nephritis were receiving an immunosuppressant as opposed to just prednisone monotherapy. Going back to that initial patient that I started this talk with, just trying to see how frequent that was. And so we looked at a sample of people in Medicaid between 2000 and 2006 in the United States, and looked at, a variety of things, like whether they had received an immunosuppressant, an ACE inhibitor, whether they were receiving hydroxychloroquine. And I think this data is depressing. Only about a third of the time could we find an immunosuppressant. And I think, it was worrisome, like many of these patients were on prednisone monotherapy. So it's not that, there was something wrong with the claim because somebody was treating them, but they just had not received a DMARD. And then, half of patients on an ACE inhibitor, about half on hydroxychloroquine, just really highlighting that, it's likely that some of the poor outcomes that we're seeing are related to the fact that many of these patients are just not getting the standard of care treatment. And, in our clues cohort, we've just asked people about their experiences with access to care. And, it's not surprising, but we see huge delays in access to care. So 92% of whites saw a specialist within 3 months of, suspicion for lupus, whereas fewer African-American and Asian patients did. There were also striking differences by the patient's level of education. Only 45% were referred to a specialist within 3 months. And those with public insurance had longer waits. These are all things that will impact disease outcomes, especially in the patients who have severe or organ-threatening disease. So one topic that often comes up as we're sort of thinking about disparities and outcomes is adherence and what role that plays. So this was a study that we did looking again at the Medicaid population. And in this study, we looked at adherence to hydroxychloroquine and immunosuppressive medications in people with lupus. And we defined medication adherence as having a medication possession ratio of greater than 80%. So, this study is, again, depressing. So only about 20% of patients who are using hydroxychloroquine were adherent using this definition. Even fewer were adherent to the immunosuppressant drugs that they had started. And remarkably, the relationship between adherence and subsequent healthcare utilization was just profound. So I think it just illustrates, if you think people are taking their medications, most likely they are not. I think the study really clearly illustrates that, and that adherence is very strongly tied to, whether or not people go on to require emergency room visits and hospitalizations in lupus. And of course, this is a very complex topic. Adherence implies that there's agreement to a care plan between the patient and the clinician. And often in our young patients with lupus, agreement is lacking. And adherence depends on trust in provider and the healthcare system. And there's often a very high degree of mistrust among vulnerable populations, and it's based on a combination of a past history of mistreatment, current perceived discrimination, and other factors. And then there are cultural differences that may exist. Populations may view illness and medications through a different lens. And so, as we try to, create interventions to improve adherence, I think it's just so important to recognize that we have to address all of these things and, really take a more comprehensive approach. Okay, so, we've talked about poverty, we've talked about quality and access to care, we've talked about environmental exposures, and I'm sorry, we've talked about adherence. So now let's talk about environmental exposures, socioeconomic status, and lupus. So we do have some evidence that environmental exposures contribute to both the onset and the specific disease course in lupus. Probably the strongest evidence is around smoking, because we know that many studies have shown that smoking is associated with both the onset and a more severe course in people with lupus. And we know that cigarette smoking is more common in people who have low income or low education. We also know that secondhand smoke exposure is higher among non-white people and those in poverty. And then there have been a number of studies that have also pointed to silica exposure, air pollution, solvents, heavy metals, pesticides, contributing to lupus disease and activity. And of course, these things are more common in lower SES groups. So we don't have time to go into all of those factors, but I did want to show you some recent studies that have been done showing the impact of toxic stress. Some of you may have seen this study looking at the association of trauma and PTSD with incident SLE in the Women's Health Study. And basically what the study found was that people who had PTSD had a higher risk of subsequent SLE in the Nurses' Health Study. We did a study using our CLUES cohort looking at adverse childhood experiences, or ACEs, and outcomes in people with lupus. This was led by one of our fellows, Kim DeQuattro. And Kim found that individuals who reported adverse childhood experiences had worse outcomes, particularly a range of patient-reported outcomes. And she also found that these ACEs were more common in certain populations, including those with lower educational attainment. This is a really active area of research. We're doing a lot of work right now to actually study the relationship between stress and disease flares in lupus in a prospective longitudinal study. We have investigators that are sort of looking at epigenetic changes associated with toxic stress exposure. So I think this story is going to continue to evolve in lupus over the next few years. And then what about biology? So, this is not a talk about the biology of lupus, but I did want to make just a couple points, which are that, I think at this point, monogenetic causes of lupus have been identified, but they are a tiny fraction of cases. Some of you may have seen the beautiful paper on TLR7 gain of function mutations in a young girl with lupus that was, on the news these last few weeks. But cases like that are still, the great minority. And, GWAS studies have identified more than 50 genetic associations with lupus, but each of these confer a very small risk. Often these studies have not included diverse populations. And, I think that newer approaches are just trying to use a more multi-omics approach to really understand, the biologic basis of disease onset. The CLUES cohort has been a wonderful resource for, our trainees and junior faculty who are looking at this issue. Christina Lanata has done some work to try to develop some subtypes of systemic lupus using CLUES. And this paper, which just came out a few weeks ago in Science, is basically our single cell RNA sequencing data in people with lupus, a very interesting read for those of you who are interested in this topic. So let me just summarize, our model and, what we know so far based on the studies that have been done in lupus. So I think we found that poverty has a profound impact on disease trajectories. We have shown that access and quality of care is uneven across populations. We've shown that adherence to medications is very low in vulnerable populations, and it actually results in more severe outcomes. There are some studies showing environmental exposures impact lupus risk, and I've shown you some recent studies on PTSD and stress. And then, we didn't have time to talk about it too much, but genetic risk is certainly important in lupus, but it can't fully explain the differences in lupus incidence and severity. And there really needs to be more work in this area. Okay, so let's talk next about interventions to reduce health disparities in lupus. Health equity supersedes the considerations of you and me. It's the ability to tackle disparities widely and innovatively. So, what are we doing to actually reduce these dramatic disparities that we see in systemic lupus? I'm going to show you sort of 3 different projects and some of the work that we're doing in this area. So the first thing is tackling communication and understanding the information needs of patients. So several years ago, the Patient-Centered Outcomes Research Institute, or PCORI, funded Jazz Singh, and I was a site here at UCSF, to do a study to develop a decision aid for women with lupus nephritis. And this study had different components. We started out by just talking to patients, qualitative methods to determine their perspectives on the barriers and facilitators to using immunosuppressive drugs. Then we actually developed a decision aid in English and Spanish to present data about lupus nephritis treatments to patients. And then we performed a randomized controlled trial to test the effectiveness of this decision aid. And I'll just show you some of the data. The first are the qualitative results. And, I think it was really important to talk to patients about the things that they thought were barriers and facilitators to treatment. So what came out on top in terms of a barrier were side effects, concerns about known or potential side effects. And we hear this in clinic all the time. People have a lot of concerns about the medications that we use, in many cases rightly, because our medications, particularly steroids, do have a tremendous number of side effects. Second most common, medication costs and affordability. So, I wish in my career, there will be a time where people with lupus do not have to worry about their medication costs and affording healthcare. But for now, it's a very prevalent concern. And then people brought up a whole range of other issues. And I think this really reflects the fact that this is a disease that impacts young women. And so they were worried about things like gaining weight, and they had a lot of concerns around pregnancy and fertility. And so in the process of developing a decision aid, we had to address these things that people cared about. And so the decision aid was developed in English and Spanish, and really it's like a choose your own adventure. So depending on the treatment choice that someone is facing, say they're, trying to decide whether to start mycophenolate for lupus nephritis, they sort of go down different paths in this decision aid. There's lots of information in the decision aid about how well each of the immunosuppressive drugs work. And we tried to gear everything towards a low health literacy level by presenting data, in a picture form. So for example, here's a comparison of cyclophosphamide and Cellcept and the benefit in terms of preventing kidney failure or the need for dialysis. And then, the decision aid goes into great detail about side effects as well. So for example, what is the risk of shingles? And, what is the risk of changes in your physical appearance? Things like weight gain, stretch marks, puffy face, or acne with steroids, and presenting this information again in picture form, and having resources for learning how to cope with some of these side effects. So we then did a randomized controlled trial to test whether this decision aid had an impact. About 300 women were randomized to the decision aid or usual care, which included sort of information that the ACR provides about lupus nephritis. This was a very diverse cohort of individuals. 47% were African-American, 26% Hispanic, 15% white, 57% had an income less than $40,000 a year, 36% had a high school education or less. And what we found was that what happened there? Sorry about that. What we found was that the decision aid resulted in a clinically meaningful decrease in the primary outcome of decisional conflict, and it resulted in a higher likelihood of informed choice. So remember when we talked about adherence, and there being a lack of agreement, this is trying to inform patients about risks and benefits in a way that allows them to actually make an informed choice that's based on data and evidence. So currently, Jazz Singh is again leading this PCORI-funded implementation study, which I'm involved in to actually try to implement this decision aid in the US healthcare system. So, often people develop these decision aids and then they just sit on the shelf. And so it's really important to actually study, how do we get this into the hands of patients and doctors and, make sure that it actually has an impact. And so hopefully the results of that will be available soon. And then there are plans to actually develop an app that we can all use in clinic when we're talking to these patients about their therapy options. All right, so another project in terms of trying to tackle health disparities is through the RISE registry. And many of you know this is a registry that we've developed at the American College of Rheumatology that really collects data from the EHRs of practicing rheumatologists across the country. And RISE, includes over 300 active practices. Some of these are very large rheumatology practices. There's over 1,000 rheumatologists, and that's about a third of US clinical rheumatologists. We have about 2.5 million patients, 23 million visits. So this now has a very longitudinal component. And this allows us to do studies like this one, where we actually can, look across rheumatology practices at quality of care and see, where we have gaps and, where we should target quality improvement efforts. So, from this study, we know that about 18% of patients with lupus have uncontrolled hypertension. We know that many patients are receiving very high doses of hydroxychloroquine, even more than 6.5 milligrams per kilogram, if we can argue about what the cutoff should be. And then we know that a substantial number are receiving prolonged, relatively moderate dose, more than 7.5 milligrams of prednisone. And so these are targets, I think, for interventions. And it's nice to be able to sort of map out the country and see where we can target some of our quality improvement interventions, which really takes us to this third project, National Education Outreach and Infrastructure to Improve Disparities in Lupus. And this has really been an incredibly ambitious effort by the ACR, as well as the Centers for Disease Control, to fund lupus-related projects to reduce health disparities. So the ACR recently received a very large grant to really do a comprehensive program across many different domains to address health disparities in lupus. Some of the really innovative aspects of this program are things like going into historically Black medical colleges and educating young women about the signs and symptoms of lupus so that they can get to care early, recognize it, in other people that they know, and, really serve as advocates for early diagnosis and referral of people with lupus. This project is also developing curricula for medical schools around the country. As many of you know, like lupus is usually not covered very well in either medical school or residency curricula. And so, trying to create materials and other resources so that we can really continue to educate healthcare professionals about lupus. There are projects looking at rural health and how to sort of improve rural health practitioners' recognition and management of lupus, especially in areas where the access to specialty care may be very limited. There's a wonderful teaching fellows project, for the fellows who are listening. This is a wonderful opportunity to get involved and do something. So the ACR actually provides a slide deck. You don't even have to make a slide deck. And fellows volunteer to administer the slide deck, do some teaching to NPs, PAs, primary care doctors, to really just provide an update on, diagnosing lupus and some initial workup and so forth. One of the projects that I'm leading in this larger effort is to develop updated quality measures for lupus that we can then, take through a national endorsement process and put into the RISE registry. And, we're developing measures around things like steroid use and also the collection of certain outcome measures in lupus. And it's been wonderful to work with both the physician community, but also patients in terms of, where we can have the biggest public health impact for people with lupus. So, as we talk about disparities, I think it's important for all of us as rheumatologists to feel empowered that, we can, in fact, make a difference to reduce disparities for people with lupus. And I think some of the things that we can all do include, making sure that we collect information about social determinants of health from our patients. And even if our own clinics are not equipped to address some of these things, ensuring that we have a list of resources that we can refer people to recognize structural and individual racism. I think once you sort of view some of our healthcare structures through this lens, there are things that we can all do to improve care for people with lupus. We can educate ourselves about cultural beliefs and communication styles and sort of use tools, hopefully one day also the decision aid for lupus nephritis, things like that, to really try to improve communication. And then I think one thing that's incredibly important is just to track outcomes in our vulnerable patients. How are our patients who are non-white with lupus doing under our care compared to other patients? There are also many opportunities to become involved in the CDC Lupus Initiative, which I told you about. It has so many different aspects and some really low-hanging fruit, like the Teaching Fellows Program, where, I think we can all participate and make a difference. A few years ago, we also started the ACR Vera Task Force Volunteers for Rheumatology Access Task Force. And you can go to this website and look for local volunteer opportunities in rheumatology in your area. So with that, I just want to acknowledge all of the people that have participated in this research over the last many years, including the members of my research group, my mentors at UCSF over the years that were part of a large P60 center, and the investigators in the CLUES cohort. So with that, I'm going to stop sharing. And I would love to take any questions.
Thank you, Jinoos. That was a wonderful start to finish, the inspiration for your research and just all of the amazing things you've done in informing how we care for patients in our clinic. We have some questions, one of which, big compliments about how you're kind of viewing these inequities. The question is, in light of all the very meaningful data you've presented demonstrating the role of social determinants of health like poverty, delays in care, and failure of standard of care in perpetuating disparities, I wonder if you can comment on the use of race-based guidelines by rheumatologists, such as the treatment of lupus nephritis using MMF versus cyclophosphamide.
Yeah, I'd be happy to comment on that. And I after the talk, I'd be happy to also provide a really nice reference on that topic. So I think one of the things that has been unfortunate is that we actually don't have much data on racial and ethnic minorities and their response to treatment in our large clinical trials. And despite that, based on very small subgroup analyses, people still sort of rush to conclusions. And the MMF and cyclophosphamide example is like a really good one. When you look at like how many patients were actually in that analysis, it was a very small number. It is certainly not nearly enough data to make any kind of race-based guideline. And I would caution anybody from taking a subgroup analysis of a randomized controlled trial that was greatly underpowered and sort of making any kind of conclusion that they then take to the clinic. So what do we need to do? What we need to do is actually enroll people in clinical trials of lupus that reflect the population with the disease. And I showed you, now we have these beautiful incidence and prevalence numbers. We know exactly who has lupus in the United States. There's no question about that. And it's on us to actually make sure that clinical trials actually reflect those populations and that we're powered to do, a priori subgroup analyses. And, a lot of people, think that it's too hard or these populations won't enroll in clinical trials and all this stuff. But I think that's been disproven. The makers of belimumab were able to perform a randomized controlled trial with several hundred people that were in the entire study population was African-American. So it just goes to show that, where there's a will, there's a way. It's possible. It takes resources, it takes outreach, it takes trust, it takes a lot of different things, but I think we have the skills to do it.
Wonderful. Another question is regarding the kind of stress and outcomes. What would you say are the most pressing questions on the interplay between epigenetic stress and issues of environmental justice, freedom from environmental toxicity, and the racial ethnic disparities in the development of lupus?
Well, I think that one of our investigators, Christina Lanata, who is wonderful, and she was at UCSF and she followed Lindsay Criswell to NIAM. So now she's an intramural investigator at NIAM. So this is her area of interest. And so I think she's studying pressing questions. Like, for example, she is looking at the relationship between stress, epigenetic changes, disease flares in this longitudinal flare study that we're doing. So I think that, just being able to even quantify those relationships is going to be really important. The other thing that they're doing is a series of metabolomic studies to really try to look at environmental chemicals that are in people's blood at the time of disease flare. And we found some things that are probably too preliminary to share at this point. It's a very messy data set because people have all sorts of chemicals in their blood. But I think we're going to be able to start to generate some hypotheses in these areas and try to answer these questions.
Thank you. Another question is generally about kind of educating patients about this disease. That's really, I mean, we still don't know everything that's going on in our patients. What are some key either resources or ways that you start to kind of educate our patients about their immune system, how we need to, take our medicines to prevent repetitive injury to kidneys? What are some ways that you approach that?
Yeah, I think one of the things that the decision aid study taught me was that, I think patients need a lot more than we're able to offer during the course of our clinic visits. And I think we all know that, right? I mean, you have a young woman, she's like 23 years old, out of the blue, she develops lupus nephritis and then has to suddenly be on 10 medications, and her life is changed. And, often even in the course of a 1 hour the doctor's visit, we just don't have enough time. So I think that is really the reason that we developed this decision aid, so that, I think in the future, how we might do things is to prescribe the decision aid, have people actually go through it, and then come to us to, answer questions and really consolidate that information so that people are receiving information from trusted sources in multiple ways. In terms of what I do right now, I think I do spend as much time as I can making sure that I'm answering the questions that are on the patient's agenda, not my own. And I think that's sometimes really hard because I feel like, we have a very long agenda when we first start, but you need to, start with understanding where the patient's at. And then I refer people to the Lupus Initiative website, because that information has been very carefully vetted. It's been developed with patients. So that's like, a key resource right at the beginning. And then I refer people to the Lupus Foundation of America. And in particular, I encourage them to participate in the support groups that are available through the LFA. And now, so many of them have virtual formats. And so people, even if there isn't one in their local area, they can participate in a virtual format. And I think just having that community to be able to answer questions, often the support groups actually have experts that come and give talks. There's just a lot of resources. So I think those are like three things that we can do now to try to, improve communication and education at the onset of disease and in an ongoing way.
Okay. Thank you for that. We have 2 minutes, and I have two questions. One, hopefully I'm just going to get like a quick snippet answer to how can you become a member of RISE? Wondering if maybe you can send me some resources and I can get it out to our group. Is that?
Absolutely. Absolutely.
Wonderful.
I will do that.
All right. And then in our last minute, like your key take home. So you've done a great job. You actually started to answer this, but just to bring it home and really emphasize in people's minds, what are the biggest interventions for these disparities that you think that we can do from a policy standpoint and as a practitioner? Just their number ones, the ones that you're most excited about.
Yeah, boy. So I think that, at the individual patient level, we should think of our clinics as really like havens for our patients. Like, how can we do everything within our domain to take care of them? And then, collect those social determinants of health and make sure that we're referring them to resources in the community. And so I think the thing that we can do is collect what those resources are and like organize ourselves around that, and sort of know what our patients are doing. At a policy level, I'm going to say something that sounds impossible, but I guess if I could do one single thing, it would be to end poverty for people with lupus, because I actually think that if we can, give people economic resources, basic economic resources and health insurance, the data show that it is likely we will have a profound impact on some of these disparities that we're seeing. Great.
Just small tasks ahead of us.
Yeah.
This is so wonderful. Thank you so much for this really well organized and holistic talk. It's an absolute pleasure having you. I know you have some one-on-ones coming up. I don't want to take too much of everyone else's time. Lots of virtual applause happening. So thank you with that, and we'll end our session now.
Thanks, everybody. You'll have a great day.